Hi, my name is Greg Scott. This is my reading presentation for Healthcare Finance and Revenue Cycle Management. This is written by J.M. Van Laer and P.H. Conway. It was published originally in 2012 in the New England Journal of Medicine. So the information is a little dated, but the core value is definitely something we can focus on. This is on value-based purchasing, national programs to move from volume to value. The National Quality Strategy of the U.S. Department of Health and Human Services oversees and defines what the Centers for Medicare and Medicaid Service is hoping to achieve through the care it purchases for individual beneficiaries. Three goals of the strategy are to achieve better health, better care, and lower costs to improve outcomes for individuals and populations at lower costs. This report takes into account reporting from 2006 to 2010, so it is a bit dated, but the reporting showed the hospital improved on 91% of measures in the CMS inpatient pay for reporting program. It also showed a trend slowing healthcare costs, but when implementing VBP programs. For example, an end-stage renal disease quality incentive program showed 56 to 96% of the facilities showed significant improvement over the first year compared to their own baseline studies from 2 years prior. According to the Centers for Medicare and Medicaid Services website, a hospital VBP program is designed to improve quality of care and the overall hospital experience for the patients. The goal with CMS is focused on the care that Medicare patients receive, but this also improves the care for all patients that the hospital cares for. A hospital value-based purchasing program encourages hospitals to improve the quality, efficiency, patient experience, and safety of care that Medicare beneficiaries receive during acute care inpatient stays. This information comes from the cms.gov website. Eliminating or reducing adverse events, such as healthcare errors resulting in harm to the patient, adopting evidence-based care standards and protocols in order to obtain the best outcomes for Medicare patients, incentivizing hospitals to improve patient experience, increasing the transparency of care quality for consumers, clinicians, and others, recognizing hospitals that provide high-quality care at lower cost to Medicare. A VBP program, according to the CMS.gov website, also can face financial penalties, with Medicare payments being withheld at 2% if the quality of care is not up to standard. So this obviously will improve everybody's hospital experience, because we're not going to change just for some people. Everyone will get this care. It uses an estimated total of those reductions to fund value-based incentive payments to the hospital based on their performance in the program. It applies the net result of the reduction and the incentive as a claim-by-claim adjustment factor to the base of operating Medicare Severity Diagnosis Related Group, or MSDRG, payment amount for Medicare fee for service claims in the fiscal year associated with the performance period. And I've included this table here for the Center for Medicare and Medicaid Service value-based purchasing programs from the article. Almost all acute care hospitals are in the program, and this affects 1% of payment in initial year for admissions, increasing to 2% in October 2017. This once again was done in 2012, so this has already passed, and would be currently in effect. Current measures include process of care, patient experience, and outcomes. So we're obviously focused on the patient, the quality of care they get. If they do not receive that care, it starts to affect the reimbursement rate from the Medicare Medicaid services. First performance period for this had ended in March 31st, 2012, and it started affecting the payment beginning October 1st, 2012. The first thing that we had the article had focused on was end-stage renal disease bundled payment quality incentive program, which whenever they started to implement this, uh, the quality of care improved. If the quality incentives are not met, then affecting 2% of the reimbursement, that starts to add up to the bottom line. If they're not getting the reimbursement rate correct because of the care is not up to standard, then generally it causes you to improve your standard of care. Current measures at the time of 2012 include outcomes, process of care, safety measures, and a patient experience reporting measure. Rewards both in achievement and improvement. So the goal is to meet the requirements, the basics, and improve on the patient care. First performance period at this time ended in 2010, and once again in 2012 it began affecting the payment. Physician value-based payment modifier. Physician payments are adjusted up and down or down on the basis of performance on quality and cost metrics. First performance period was in 2013, and it started affecting payments in 2017. Some physicians were eligible initially, and by 2017, it expanded to apply all physicians. The article focuses on 6 domains of quality measurement. They would be safety, which is obviously patient safety, healthcare acquired conditions such as falls or diseases that may be acquired in the hospital, such as MRSA, pneumonia, things of that nature. We want to improve the overall condition for the patient. The focus should be patient and caregiver-centered experience, which will help improve outcomes. That focuses on patient experience, the caregiver experience, and the patient-reported outcomes. So obviously we want to see improvement as the patient goes into the hospital, and we don't want to see them end up back in the hospital in a readmittance occurrence because of something that happened. So that would also involve care coordination. So that would be admission and readmission measures, care coordination measures, provider communication. The clinical care, we're focused on for these CMS requirements: acute care, chronic care, prevention, clinical process measures, and outcomes. Population or community health. So we're also looking at the overall population of the area, not just the ones that have to come into the hospital. We're focused on health-related behaviors, access to care for these individuals, determinants of health, and disparities. Once again, you have some patients that do not have the money to be in the hospital. Other people may have the insurance, so that's obviously going to affect outcomes as well. If the patient doesn't have insurance, are they going to be able to follow up with their physician? Are they going to be able to do the preventative care necessary? And we're also looking at efficiency and cost reduction, annual spending measures, such as per capita spending, episode cost measures, and quality to cost ratios. So it's also about trying to figure out ways to do more with less. That if we can decrease the amount of money being spent and improve the quality, obviously that's better for the hospital's bottom line. The article discusses 5 principles of developing a VBP portfolio for a hospital or healthcare institutions. Programs must define the goal to achieve the desired result, but not the process. So we're not trying to figure out exactly how it's going to be done necessarily. We are just trying to identify what needs to be done and then kind of fill in the blanks as we go. All providers' incentives must be in alignment with the desired goal. Proper methods must be developed and implemented in a rapid fashion. So things have to happen quickly if we're going to get it done. Centers for Medicare and Medicaid Services need to be actively support the quality improvement program. So they have to work hand in hand to guide the hospital. Both the hospital and its patients need to actively be engaged in the VBP program for it to work. If not everybody's on board, it may not work out as well. So sometimes a hospital, the nurses will need to kind of script things, doctors will script things to let every keywords
be known to the patient so that they kind of know why we're doing it. Then when the questions are asked later, they'll be able to say, yeah, I did receive that care. So sometimes there's some scripting involved on the healthcare provider side as well to achieve these desired results. And this is the references I utilized. One was from the Center for Medicare and Medicaid Services.gov, and the other one for the value-based purchasing. I hope you enjoyed the presentation. I really enjoyed reading this and learning more about value-based purchasing, and it's really improved my knowledge of it, and I hope it has helped you as well.